Good afternoon, everybody. Thank you for joining. We are just waiting for a few more people to join. If you are a committee member, if you would put your name in the chat. Also, if you are a committee member on the phone, if you would let us know that you are here. Thank you. Okay, we've had a few more people join. Thank you, everybody, for joining the call today. Again, if you are a committee member, if you would put your name in the chat. And if you are a committee member who is on the phone, if you would let us know that you are here. Thank you. We should get started here momentarily.
Thanks, Sharon. Do you know if we have a quorum yet?
I was just trying to do the last count. Last count, I was one short, so maybe give it another moment. There we go. Lots more people joining.
Okay.
Okay, we have met our quorum. Thanks,
Great.
Jesse.
All right. Well, welcome, everybody. Hi, my name is Jessie Mandel, and I'm chair of the Medicaid Advisory Committee. Welcome, everybody. This is an open meeting, so please remember that you're welcome to ask questions, even if you're not a committee member, or participate in the chat. This is a meeting that's open to anyone, and anyone's open to participate. So let's get started. First, I just want to make a quick announcement that we've determined for the foreseeable future that we will be meeting virtually over Google Meet or by calling in, and we will not be meeting in person. And you'll probably all be happy about that since I think I have a cold. So one of the many benefits of virtual meetings. So until it's further determined, we are still meeting virtually. And with that, let's look over the October minutes, and whenever a committee member is ready, I can seek a motion to approve the minutes. These are for the October minutes that were attached.
Jesse, it's Joey. I make a motion to approve the October minutes.
Great.
Jennifer Lloyd, I would second that motion.
All right. Thank you. Okay. And another update, we have yet another member leaving us. Adam Cohen, who has been on the MAC for quite some time, is terming off from the business representative position. And so we will be seeking nominations to fill his role. He's in the consumer or person with lived experience category. So we'll be putting out some calls for filling his seat. And I think, Adam, your last meeting is in December. Is that right?
That is correct. I don't think I have seen him on.
I don't think so either. So
yeah, but yeah, he will. His last meeting is in December.
Okay. So we'll be so if there's nominations, and we can send out information about the nominating process for his seat or for the open seat after this meeting. Sharon, do we have any updates about the other open seat, the home health seat?
I believe we are still making decisions. I don't know if Emma can shed more light. But
Yeah.
we received 2 nominations.
We don't have that finalized yet, Jesse, so we will by the next meeting.
Okay.
Or before the next meeting, let's put it that way.
Okay, that sounds great. So at the next meeting, we'll likely have our new seat for the home health position, and then we can, if there's any nominations at that meeting as well for the seat that is currently the business community consumer representative seat, which no longer needs to stay, does not need to just be a business community. I think it can be broadened than that. As I say this, I need to check the bylaws, but we can send out more information about that after this meeting. Unless Michael or anyone has the bylaws memorized, that they have that off the top.
The bylaws are not specific to the business community, but just making sure we've got representation. So.
Yes. Okay, good. Got it. All right. Well, thank you. Thanks, everybody. All right. Our next agenda item is committee member updates. So committee members, MAC committee members, if you have any updates, news, questions, anything to share at this time, just always leave some space on the agenda for any updates or things to share out. Michael.
Thank you, Madam Chair. As a follow-up to our meeting last month on the Medicaid Expansion Fund, I just wanted to bring to the attention of the committee that the Legislative Fiscal Analyst's Office released a report just earlier this week in Executive Appropriations that included some information about the Medicaid Expansion Fund. It did show the same balance that Eric presented in our last meeting, that the fund is at $158.9 million, but also showed that the forecast for the current fiscal year projects revenues exceeding expenses by $16 million, and that's even after the legislature took out $56 million of one-time funds, and that for fiscal year 2023, where the ongoing $56 million is still assumed to be in play, that the projected revenues will exceed the projected expenditures by $71 million in that fiscal year, which shows a projected balance, if all goes according to the projections, of $246 million in the Medicaid Expansion Fund. And that's with over $168 million being diverted out of that program over 3 fiscal years. So I just wanted to follow up with that. There have been some questions if current revenues are covering current expenses, and they are, and they're projected to continue to do that for the next couple of years. So I just thought I would share that as some information, if not everyone digested the EAC document, just so people have some visibility to that. So that's my share. Jesse, back to you.
Thanks. Emma, will you be talking about this report more in the director's report?
No, I hadn't planned to.
Okay. Well,
So I could have questions if people wanted to, I guess, if that's of interest. But.
Well, thank you for sharing that. I'm curious if that was anticipated by the department, if there were any surprises in that report.
I think the report is a reflection of our discussions in consensus. So no, not surprising. I mean, it's a pleasant, I don't think we expected it to look that good until we got to consensus. So, but it's a pleasant surprise.
Right.
Eric, did you have anything you want to add to that?
No, it's good news all around.
Yeah.
The fact that there's a good, healthy surplus in there means the program's going to be viable for several years to come.
Yeah. Great. Stephanie?
Yeah, so did you say that is in the consensus report then, Emma? Does that mean that the whole consensus report was discussed in executive appropriations?
I think what the LFA put out is basically a synopsis of the consensus discussion. I think that's the report you're referring to, Michael. Is that correct?
Yeah, it's every year in the November EAC, the fiscal analyst presents a document titled Medicaid Consensus Forecasting, and I can put it in the link for people who want to reference that. Just a minute.
Is that also where they discuss the rate increases? I feel like that's happened in the past, but maybe I'm misremembering.
So it would discuss generally like how much is being put in consensus in the base budget, consistent with this, state statute for the ACOs. So it should, I believe it addresses that issue as well. So pretty much just gives an overview of the outcome of the consensus process.
Cool, thanks.
Thanks. Courtney Bullard, your hand is raised too.
Yeah, I just wanted to echo, I think it's really great that the surplus was included, and I think it's really excellent that we have that. I was just wondering if the department has any ideas of recommendations to give on what to do with the surplus, or if the legislature has asked for recommendations on that, and I guess the third part is, do we have any indication if the legislature wants to continue to start taking from the expansion fund again, since there is such a healthy surplus?
I mean, I think there's always a discussion about the state general fund that went in to the expansion fund and whether or not that could or should be used, although I'm not aware that any decisions have been made. But I think what we're saying, there's a couple of things here. One is that everything is still entirely up in the air because of the public health emergency and the maintenance of effort, and not knowing how quickly we're going to get through that process. And frankly, even more important, how many of the individuals that are currently on because of the maintenance of effort really will stay on because they're eligible. So I think it's a little bit premature to discuss what to do with that surplus at this point in time, because we don't know when the dust settles what we're going to have left. I think we've got a couple of things going on. It's amazing to me that we have this surplus with so many additional people on the program, but I do think we're also seeing for some of our groups in Medicaid expansion, we are seeing their costs slowly come down, and I don't know if that is truly an ongoing reduction in costs because pent-up demand, we've kind of gotten through some of that, or if those costs are a little bit less than they would normally be because we're still in the midst of COVID. It's just hard to know. So we haven't talked about other ideas as far as the additional funds in that account.
Thank you. Do any representatives from the health plans have further insight into the per member per month decreases that were illustrated in the EAC report? Because it seemed to be pretty significant to me. So I think I'm with Emma. I wasn't quite sure what that could be attributed to.
Well, the report did talk about some run out from fee-for-service as some of the population had claims continuing on while the population, or a significant portion of the population, was put into the ACOs where the premiums are paid before the beginning of each month. So when that happens, you're artificially high for a period of time until the previous claims run out takes place. And that was called out in the report as a factor.
Yeah, I think the other area, actually, the one group where we have seen it, their per member per month cost coming down, and these individuals are not enrolled in managed care, our targeted adult Medicaid group. And that's where we think some of the pent-up demand we may have gotten through some of that. But again, we haven't had time to really dig into that analysis and see, compare year for year what's going on there. So that is not something that the plans have any control over right now. So that's why I think it's either attributed to pent-up demand, maybe better access to healthcare, or it could be that because of the pandemic, some individuals just aren't seeking care. So that is something I think we should look into just to get a sense of that, but we haven't yet.
And maybe just one other thought in terms of people getting excited about diverting the funds. I think the money is put into this fund for the express purpose of covering the expenses of the expansion population. And I don't think that there's a lot of latitude for moving that money elsewhere. And in fact, if the balance in this account drops too low, there are some pretty draconian cuts required on all of the social service agencies and many of their programs before additional funding is considered. So if anybody wants to revisit Senate Bill 96 from a few sessions ago, you'll see that there are like 10% cuts in many programs and many state government agencies that would be required before additional funds would be put into this account. So before we spend the surpluses, I was just hoping we could celebrate that the revenues that are going into the account are sufficient to cover the expenses despite all of the gloom and doom forecasting that has been in place for the last 10 years, that it would be unsustainable, like the Medicaid program is frequently accused of being, but that the revenues generated by the sales tax and the other supporting hospital assessments are currently covering the expenses, and that's good news.
Yeah, I think that's a good point, Michael. And the one other thing I was just going to mention is, so we continue to work with CMS on getting the housing support services portion of our 1115 waiver approved, and I think we're on the verge of that. I thought it was going to be by the end of this year. They basically said to us it's probably not going to be by the end of the calendar year. It will probably likely to happen in January or at least the first quarter of next year, simply because of their workload. But keep in mind, we haven't even started spending any funding on that particular service, and we think that there's going to be several thousand individuals that will qualify. So again, I think to Michael's advice, we probably should just take kind of a wait and see until we implement that piece of the program, see what happens with the maintenance of effort, and hopefully the fund will continue to be sustainable for many years to come, because of the worst case scenario is a 10% reduction in the budgets of workforce services, human services, and health is the last straw in the bill, and that's pretty significant if they have to make up that any sort of ground.
All right. Thank you. Thanks for those updates. Thanks for those questions. That's great. Appreciate that. All right. Well, thanks.
Jesse, can I?
Yeah.
Andrew, can I ask a quick question of Emma?
Yeah.
Emma, we heard a rumor last week that caregiver compensation is ending as of the end of the year, because at least part of the reason apparently CMS didn't allow it to continue using the enhanced Medicaid match. Is that the case? And are there any plans to look at ways to continue that?
So, and I don't know if Tanya's on the call. I believe she is.
I am.
Yeah, so that is true, to the extent that CMS did give us a response that we could not use the ARPA 10% FMAP to fund those services. And Andrew, I know you're aware of this, but for others, these services have really only been continued past the end of last fiscal year, because DSPD has been able to use some carry forward money to be able to continue those services to the end of December. And Tanya, I don't know if you want to fill in some of the additional information on that.
Yeah, and thanks for the question, Andrew. I think the position that CMS is taking, since we submitted our HCBS spending plan in June of this year, we've had multiple conversations with CMS about provisions of the state's proposed spending plan. And many of those conversations have focused on this topic of family caregiver compensation. And CMS has continued to take the position that to allow the use of the HCBS ARPA funding for the purpose of caregiver compensation, essentially their argument is that it would amount to supplanting of funds that were already intended for this purpose prior to April 1 of 2021, which is what the provisions of Section 9817 of the ARPA legislation requires. And we have taken multiple attempts at trying to demonstrate to CMS that this was a temporary program. It was only allowed through the enhanced FMAP of the CARES and FFCRA provisions during COVID, and we have been unsuccessful to this point. So we're really disappointed by CMS's interpretation. And that's kind of where we are on that specific topic. There is some discussion. I mean, there's been multiple discussions. As you know, Senator Harper, a bill passed last session that allows us on an ongoing basis to allow for spouses to be paid caregivers, to receive compensation on an ongoing basis beyond the public health emergency. But to date, we don't have the ongoing appropriation to allow the family caregiver compensation to continue beyond just spouses. So that's kind of where we're at with that.
Okay. How are you? Thank you for providing that detail. And just in case we or others get calls related to it, how are you? How many families are currently receiving compensation, and how are you working with them to transition away from it and into other services if possible?
So it's approximately, we were just looking at this number recently, Andrew, and it's about just over 500 families that have benefited at one time or another since the implementation of the caregiver compensation that have received this support. I'm not sure how many families are actively engaged, but it's just over 500 since the inception. And I know it would be great if Angie was on the call too, but I know that a letter was disseminated, an email was disseminated to the impacted families with guidance to work with the case managers and support coordinators of the individuals receiving waiver services to try to identify where their service needs may be met from other services that are covered within the waiver.
And Tanya, I think didn't DSPD also send a communication to the support coordinators and case managers as well to give them a heads up?
Yep, that's right.
Yes, Jennifer? Jennifer, did you have a question? Oh.
Can you hear me? Okay, sorry about that. I just have a quick question. I wanted to clarify, as of this moment, only spouses are eligible for caregiver compensation and not children or grandchildren?
Yeah, Jennifer, so right now, through the end of the calendar year, there is funding has been identified to allow for the family caregiver compensation to apply to parents and others in addition to spouses. But
Oh.
the legislation from Senator Harper that passed last session was specific to spouses. So that portion is going to be allowed to continue ongoing, where the compensation for other types of caregivers like parents and guardians the funding is only available through the end of the calendar year.
Okay. Thank you.
Thank you. Thanks, Andrew, for that question too, and Tanya for that update. Okay. If there's no more questions on that piece, and maybe we can do another update in December as well. Laura, it's over to you for the waiver, the public hearing.
Great. Thanks, Jesse. So today's public hearing is for two 1115 waiver amendments. And I'm going to go through both overviews before opening up for public comment. So we'll start with House Bill 34, which is medical respite care. So medical respite care is the result of House Bill 34 that was run through the 2021 general session, titled Medical Respite Care Pilot Program. This amendment seeks approval from the Centers for Medicare and Medicaid Services to provide temporary medical respite care for homeless individuals covered under the Adult Expansion Medicaid program. As far as eligibility, individuals eligible under this demonstration must be Medicaid eligible individuals who meet all of the following requirements. An individual is covered under the Adult Expansion Program. An individual is chronically homeless or was chronically homeless and is currently living in supported housing for the chronically homeless. In terms of benefits, qualified Medicaid members will be eligible to receive the following services: time-limited medical care in a stable environment, and the maximum benefit period is 40 days in a 365-day period, and this is assessed based on a rolling year. The proposed demonstration timeframe: the state intends to implement the proposed benefit as soon as possible after approval. In terms of population impacted, we expect approximately 400 to 500 individuals may be eligible per year if this amendment is approved. And for the provider, one provider will be selected as a pilot through a public procurement process. And then we can now move on to House Bill 192. This is fertility treatment for individuals diagnosed with cancer. This is also the result of, run through the 2021 general session, House Bill 192, titled Fertility Treatment Amendments. This amendment seeks approval from the Centers for Medicaid and Medicare Services to expand Medicaid coverage for fertility preservation services for individuals diagnosed with cancer. In terms of eligibility, Medicaid eligible individuals under this demonstration must meet all of the following requirements. They must have reached puberty up through the age of 40 and diagnosed by a physician as having an active cancer diagnosis requiring treatment that may cause a substantial risk of sterility or iatrogenic infertility, which is infertility caused by cancer treatment. In terms of benefits, if approved under this demonstration, qualified Medicaid members will be eligible to receive the following services: collection of storage of eggs or sperm consistent with established medical practices or professional guidelines published by the American Society of Reproductive Medicine or the American Society of Clinical Oncology. Storage is covered as a single payment in 5-year increments as long as the individual is Medicaid eligible. The proposed demonstration timeframe: the state intends to implement the proposed benefit as soon as possible after approval, but not before January 1st of 2023. And in terms of if this amendment is approved. And the demonstration amendment documents are available on the 1115 waiver website, which the link is provided here. And I am now opening the hearing for public comment. Andrew?
Yeah, Laura, thanks. I don't have a comment at this point. It's a question, and I was just curious if you could. I believe that you said that there is a that the medical hospice limit was 40 days in a year, and I was wondering if you might be able to shed some light on how that number was decided upon.
Laura, do you want me to take that one?
Sure. Thank you, Tanya.
Yeah, thanks, Andrew, for the question. One of the things that we were trying to do in balancing this service is trying to make sure that we have an opportunity to provide more acute, time-limited services to individuals who may be discharging from a hospital and maybe in need of, IV antibiotics and need a safe place to receive that important medical care. And one of the things that we looked at was the respite care that's provided in some of our home and community-based waiver programs when that care is provided in an inpatient setting, such as a nursing home, for example, with the New Choices waiver. We do impose some limits on the amount of time that someone would spend for a service to be considered respite. And so with that in mind, we had originally kind of crafted the language to say that somebody would get like 4 10-day period, a maximum of 4 10-day periods, for example. But then as we talked with clinicians about that, we decided that we didn't want to be that prescriptive and wanted to just allow for 40 days of treatment, and it would be up to the clinical folks who are managing individuals' care to figure out if they needed 20 days, to run a course of antibiotics or whatever the case may be, that they would have that opportunity to have that flexibility. But we also wanted to make sure that it was really clear that it's a time limited service. So that's how we came up with the 40 days. And, we have we'll be doing an evaluation of this service over time. And I think that will give us the opportunity to better understand what utilization looks like. But that's where we're starting.
Tanya, can I ask a quick follow-up?
Sure.
And that is, I was just wondering if there had been discussion. I'm assuming, and I don't know, but I'm assuming that at least some of this population will be higher acuity than a majority of the regular Medicaid population. Did that factor into the discussion at all?
Well, I don't know that specifically. I mean, I think one of the things that we're looking at and what some of what prompted this is just a recognition that many individuals who are homeless may not have, some may have chronic conditions, but there are others who, may just have like a wound or some temporary kind of issue. And I think that this 40 days also reflects some of the experience by some entities who are providing this kind of care already. And there was a belief that this limitation would meet the needs of the majority of the individuals who have, Medicaid hasn't been paying for, but who have been receiving this type of service that has been kind of funded through means that are kind of cobbled together. So I think that's the basis upon which we decided to go with that 40 days.
Thank you. That's what I was curious about, whether it was based on experience or feedback from folks who have been treating folks in these categories. So thank you for that information.
Sure, thanks.
Looks like Ron, you have a question or a comment.
Yes, I do. So my name's Ron Fairber. I'm the treasurer for the Disabled Rights Action Committee. And I just wanted to make you guys aware that, and you probably already know this, but there's a huge emergency situation with home care services, aides, nurses, case managers. None of these agencies, they've got applications out, I mean, job postings everywhere, and nobody's applying. We have a serious reimbursement rate problem because inflation's gone up and people just, it's hard work to come into a home, care for an individual, bathe them, feed them, take care of them, and get paid, not so good wages. I think with the inflation going up, we're just not meeting those current rates of reimbursement, and just people are not. They're leaving in droves. And what's happening is those who are staying, the nurses who are staying on, the case managers who are staying on, and the CNAs who are staying on, they're burning out fast. And what they're doing is they're taking on 2 and 3 times their caseloads, and mistakes start happening. And I know it's a combination of the pandemic, but this inflation's really hit us hard, and I think we need to seriously and quickly move at boosting those reimbursement rates for these employees, because it's hitting. It's an emergency situation right now.
So Ron, this is Emma. So we are very well aware, and it's not only hitting that part of our program, but all sorts of areas of our program. But we also know we've very much made the executive branch, all the way up to the governor's office aware, and legislators are aware as well. So one of the things that we are doing, and which is not related to these amendments, but is the ARPA funds that we are able to get now because of the increase in the federal matching rates by the 10%. We are using that to make supplemental payments to specific groups of providers. And I think Tanya earlier alluded to our ARPA spending plan that we submitted to CMS. And one of the things that we are asking providers to do when they get these funds is to attest to the fact that they understand that they're temporary, although I know that there are some discussions going on by decision makers saying, this really is a problem. We need to figure out a more long-term solution to this. But also we're saying to these providers, you need to attest that you are going to spend, the bulk of these additional funds we're giving you on direct care staff. And so the idea being to increase reimbursement for direct care staff to try to address this very issue. And these additional funds are going to be available through March of 2024. So that gives us some additional funding for the time being, but I think everyone's recognizing this is a longer term problem that is not going to go away, and we need to figure out a longer term solution. So I appreciate you bringing it up, because we need to keep everyone's eyes and attention on this issue.
Thank you.
Jennifer, question or comment?
Yes, I just wanted to thank Ron for bringing this up, because this kind of relates back in a way to caregiver compensation. Like Ron said, there is so much turnover, and it's so difficult to find staff to care for loved ones, to get them bathed, to get them fed. And then when they leave, home health, then the family members have to pick up the pace, and then there's no caregiver compensation. And so it's just endless ping pong game. So thank you, Ron, for bringing that up. What he's talking about is very true, very serious. So thank you.
Okay, and just to go ahead, Jennifer.
Thank you. I'm just commenting to let you know that Ouch will be submitting comments on both of the waivers. We are generally supportive of both. I think on the fertility one, our main concerns focus on we'd like to see some description about the process that will take place once the eggs or sperm are stored, and then how or if there would be any fertility restoration pieces funded in Medicaid or not for folks who might still be on Medicaid when they're hopefully successfully treated for cancer. And then on the medical respite, again, we are generally very supportive of it for homeless folks. Having surgery and being turned out on the street the next day just sounds horrible. I think our concerns are with the single entity arrangement because that wouldn't provide statewide coverage. For example, we know there are homeless persons in St. George, and it would be tough to get them up to Salt Lake. And we would like to see a broader definition of residential facility. And our other concern is that this has language that requires, quote, someone be chronically homeless. And we know from 4th Street and from other health centers that have worked with the homeless that documenting that chronically homeless status is really challenging. So excluding persons who are homeless but just cannot meet the definition will exclude some people who would really benefit from the medical respite. And it would even make the pilot project more difficult to evaluate since you're leaving out a big section of folks who are also experiencing homelessness. But again, in general, we are supportive and will be submitting formal letters with more detail. Thank you.
Thank you, Jennifer. And just as a reminder, you can continue to provide comments, and as you were notified, we have extended the public comment period through December 15th.
So I think, Jesse, I think typically we just open it up towards the end of the meeting, right? It's just for the listeners to know, to see if anybody has formulated any additional comments before we end the meeting today. And then as Laura said, you have until December 15th to submit comments to the division. And we appreciate the feedback. We appreciate the additional sets of eyes and thoughts about how we can make these better. So thank you.
Great. Thanks. And Gina, did you want to make a comment, or is that just a comment for the chat? I didn't know if that was specific to the waiver. To Gina Tuttle. Okay. Okay. Well, thanks, Laura. And if there are any other, again, as Emma said, if there are any other comments, we will make time in this meeting, or please submit them online. Okay, great. Well, with that, let's turn over to Jeff and Merce for the enrollment in the expansion discussion.
Thank you. It's good to be back with you again. I can't believe it's November. Sharon, if you'd be so kind to share the chart again, thank you. If you could just zoom in on the the numbers for us a little bit. And again, these handouts are in the invite today, so if you want to pull up these numbers, you can look at them individually. Why don't we get started with, there have been a couple of changes. So one thing to note, I believe the numbers in October, some of this is timing. You'll see a little bit of a decrease across the board here for people over 65 with disabilities, et cetera. You'll see a decrease from previous months. That could have a little bit to do with timing. However, one number I did want to call out, on the pregnant women, we saw a decline of almost 4 times what we have been seeing in previous months. As DWS and myself, we talked about this a little bit. DWS has been, all of us are trying to prepare for what happens when the public health emergency ends. And in so doing, some of those actions are now being taken a little bit more seriously by some of the eligibility workers. So there was a push to try and make sure that people are getting into the right program. What that means is you are able to move a pregnant woman from who is no longer pregnant to a different program within the Medicaid structure. That's occurring with more frequency now. So that is one that did make some sense to us. The rest of the numbers are slightly lower than what you've seen in the past several months. Let me pause and take Stacy's question there.
Yeah, just real quick. When did you start shifting folks from the pregnancy category to the correct category?
It started in roughly November. Well, we got the guidance in November of last year, a year ago. I can't believe it's been a year. That's when we got the guidance. I think it took us a couple months to get that to DWS. So about January of this year, you'll start to see that decline. And if you look back at our numbers here for pregnant women, you really start to see those impacts in March of 21.
Thank you.
It's a great question. Oh, thank you. I feel like I've got Vanna White here doing the numbers for us. This is fantastic. All right, and you do see a slight decline in CHIP, but again, I do think that decline is probably more on par with what we've seen the last several months. Again, timing means something in some of these months, and this happens about every 3 or 4 months. We'll probably see a larger decrease in November, would be my expectation. If we can move down to the lower graphs, and these don't have a lot of change to them. We're just trying to go through quickly so we can talk about some of those other items on the agenda today. But you will see that the adults continue to climb in the rate that they have. That hasn't changed. People with disabilities slightly up. People aged over age 65 again slightly up, and you can start to see that slight decline in the pregnant women overall. And then moving to the children. Again, it's on par with what it has been for the past several months, but maybe it's, we're working towards that peak. Not sure what that peak will look like until after the public health emergency has been declared over, I'm sure. And with that, we can move away from the numbers. Unless there are any questions on the numbers, I'll pause here.
Just a question. Do we have on the trend lines the new enrollees? I know we talked about this a while ago, new enrollees versus people that are staying on because of the PHE continuous eligibility. Like, do we have a sense for how many new people are coming on?
That's not one that I can as easily answer. This chart does not show that. This is just looking at total enrollment, of course. And thus, Maris, maybe you want to chime in if you're seeing an uptick in applications. I mean, it is open enrollment right now, so that is occurring, and that will bring in, but you won't see that for a month or two. Anything else,
Jesse, I think one thing that we don't really have is a definition, what is a new enrollee? And perhaps we can kind of clarify that as well. Let's say somebody has been with us for 6 months ago, and they're coming back and re-enrolling. Are they considered a new enrollee, or are they re-enrollee? So we don't, like Jeff said, we don't have a specific number that we can say this is new enrollees, because that definition is kind of vague at this point. The thing that I'll comment also, the FFM open enrollment has started. We thought it would be a non-event this year, but it's been a little bit larger than we anticipated. Meaning we've had roughly about 500 account transfers daily since November 1st, and that's been the pace that we've been maintaining. We have not seen an uptick in the applications except for the change with the FFM coming over.
And Maris, for your question, I would imagine that a new enrollee would be maybe somebody that's coming back onto the program, since no one should be dropping off. So normally I would think about, when that question, like new enrollee, we think about the churn piece. But since we're not seeing the churn, we shouldn't be seeing churn right now, then I would say new enrollees are just people that are applying. And I'm just curious how many new people are applying versus how many people are staying on.
Just even though that's not something I have on me, that would be something I can fairly easily get for you. Basically get you the number of new Medicaid applications. And if you want to make that conclusion, these are all new, we can certainly do that.
Thanks. Yeah, I can follow up with you. Thanks.
Okay.
And then for some new pieces today, we do have some new questions on the agenda for us. And the first one's about the public health emergency unwinding. So just want to very quickly state the public health emergency is in effect till mid-January. It is still out there. That is not changed. This effort is really talking about what happens when it does. So when the public health emergency is over, well, it's been termed unwinding. We talk about them as forced cases sometimes. We talk about them as a backlog of cases, a lot of different names for that. What we're talking about, though, are the folks that we've kept on that we're just talking about moments ago, Jess was talking about. And what that looks like when we go back and look at the eligibility over the course of 12 months from the end of the PHE, again, not knowing when that's going to be exactly. So those plans have begun. We have, the Department of Health, are talking with Workforce Services, trying to look at what we technically are able to do, talking about the guidance that CMS has been giving us as far as what needs to occur, allowing 12 months to actually do a renewal for each case, et cetera, and trying to figure out what that plan might look like. We don't have a plan yet to share. We hope to have one soon for you, but those conversations are occurring. We are trying to be sensitive to each group of individuals that we cover and how to best serve them as we go through that process. It's gonna, there are moments in eligibility. This is one of those large moments in eligibility, I think, where we want to be careful about how we take this on and proceed very carefully. It's as big to me as the ACA was back in 2014. We want to make sure that we do this the right way. And so those conversations, again, are occurring every couple of weeks right now with DWS. And we do have plans to have a written plan in front of this group as soon as we possibly can. Stephanie?
Hi, thank you for your work on this, Jeff. I'm curious about with the merger and like different conversations about like the small pieces that are moving over to DWS, who has the final say on how the unwinding happens? Because is this one of those policy decisions that is like, who's going, how is that, what's the decision-making flow chart?
We do work together with DWS. If it came down to a decision like that for final say, the final say rests with the single state agency. But I would say overall, this is a plan that we're doing together. This isn't something that either one of us is trying to go without the other. DWS need our help and we need theirs.
I would agree. This is Emma, but I think this issue is big enough, Stephanie, that we've actually discussed this issue with the governor. So I mean, it's not just a matter of our folks working together, which they do on a regular basis, but there are huge implications. There's implications financially to the state. There are implications in terms of continuity of care and making sure that individuals who are eligible, I mean, one of the tenets of the Medicaid program is that individuals who are eligible should be eligible. And we want to make sure that eligibility is not disrupted. And because when it is, it has such a ripple effect everywhere, to all of our provider system, to our managed care plans, and most importantly, to those individuals. And so at the end of the day, this is something that the Governor's Office of Planning and Budget has been involved in the discussion. We've brought this to the attention of key legislators. This is not something that is going to be done in a silo because it has huge implications. The other thing I would mention is I don't know, how much validity there is to this, but technically based on the fact that CMS has said that they will give states 60 days advance notice when the public health emergency is going to end, those 60 days would have been this week. So we're anticipating that there is some chance that the public health emergency will be extended again, even after January. So I'm glad because that gives us a little bit more time to work out the details. But just so you know, that was brought to our attention as states this week. It's like, oh yeah, if it was going to end in January, they technically should have said something a couple of days ago. So we'll see what happens.
Thanks, Emma.
Yeah.
And there are a lot of moving pieces to this too. They're very, as simple as turning on CHIP premiums or charging spend downs how each of those steps occur and what that looks like. We're trying to consider each and every one of those items for each type of program that we offer. And I thought it might be helpful at this point just to insert how many people we think are in this backlog that need to be reviewed. This is a rough number, but it's approximately 130,000 individuals, and approximately that's 73,000 cases. And that's an average over the past several months, but we're still trying to gather our arms around what the work looks like, and even trying to get the reporting to work to say we've got everybody or don't have everybody. That's tricky for us, but that gives you a rough idea of how many people we're talking about.
And I think Stacy has also made a good comment. So the Build Back Better bill, and who knows whether or not it will pass or not, because that is the more controversial human infrastructure bill in Congress, but there are some significant changes to the unwinding of the maintenance of effort, as well as the continuation of the enhanced federal match. So if that passes, then our plan will have to be reworked based on the provisions of that piece of, that bill in Congress right now. So
we should also add that CMS has yet to give us all of their guidance as well. CMS has promised more guidance that has not yet shown up. Sorry, Stephanie, go ahead.
Oh, no, thank you. And I appreciate what you both say, and really agree with Emma about how important it is that those who are eligible remain enrolled and able to get the health care that they need. I'm curious, do you know at what stage it would be helpful to have some feedback about how to get the message to the Medicaid community, and maybe talk about different whether it's actual locations where getting this message out, or different communication channels, or working with community health workers, peer support specialists, people who are more connected into this community. I don't know if that's, just curious when that might be something that you all would be interested in having some feedback on.
I'd say at any time. I mean, definitely when we put the plan out to get some feedback, but if you've got ideas now, we will take the ideas as you have them, because I think that's key. The other thing that Jeff may have on his list to cover, but I think in our last meeting, we had talked about the fact that to us, a really big piece of this is making sure that we know how to get to people, because no matter how we communicate, if we send out a notice and it's going to the wrong address, that is not going to do those individuals any good. And so we're working on more of a communication plan there as well. But I think we mentioned in our last meeting that we were going to have our health program representatives start updating addresses. And the first week, I believe, or I think it was week, that they started. So right now, when somebody calls into our health program representatives for any reason in Medicaid, they're asking, can we verify your address? And they basically updated 500 to 600 addresses, 20% of their calls were people who were saying, oh no, my address is incorrect. And this is the address we're getting from EREP. So I think that's an indication of how bad the addresses really are, because people are not, and I don't blame folks. I mean, they get told there's a 10-day requirement that they're supposed to keep their information updated. But if you don't have anything pressing you to do that, and you've got other issues in your life, that's not the first thing that occurs to you. So to me, that is just really critical too, is just to keep telling people, make sure your address is current with Workforce Services, make sure you let them know so it can get updated, because that was a pretty good indication to us how bad the addresses really are.
Yeah, I think for a lot of member perspectives, it's really, if you think about how many different agencies they might be interacting with, as well as doctors, you think you would update it with Intermountain, so you would assume everybody else, Select Health, Medicaid, DWS, you just logically think that everybody's going to figure it out. They don't. So I don't know if there's any way that y'all can do that, where people might be more likely to have, the healthcare system might have a more updated address than the government. And so I can't remember what it's called, and Jesse, chime in if you do, but isn't there something where you can what's it called? It's that information. Isn't there some process where you can kind of get some of that data updated, more like automatically? Just like,
yes. So to answer your question shortly, yes. There are several groups, of course, that are selling products that want to reach out to the state and try to match data with us right now. There's a possible chance to tie to the United States Postal Service. There's things that other states are trying to figure out as well. How do we get these things up to date? I think that the one that Emma just mentioned, and yes, I was going to certainly cover addresses. This is very important. Just having those moments, we have natural touch points with people. Simply asking that question and having them report what they have, has been, I think, huge for this group alone. I think as DWS starts to implement that same practice, I think that's also going to help to get the addresses up to date. DWS takes hundreds of thousands of calls each and every month, and asking that question, although it takes a little bit of time, is going to pay dividends.
And our plans are doing the same. I mean, we've asked, our plans, because they all have customer service, units as well. And as they get updated address information, they are sending that actually to our HPRs to update the information. So at least to that extent, we're all trying to get that information and get it into a central point. And I'm not aware of any centralized way to get the whole healthcare system to do that. But, certainly I think with our ACOs and our prepaid, mental health plans and DWS working on it and us, we're hoping to get as many as we can updated, because the key is going to be getting that review out to them. And if they can't get it, they're just automatic, if it doesn't get to them, I mean, DWS can only assume that they're just not responding and the case will get closed. And that's not what we want to have happen. So.
And Emma, from the health plan side, we're doing everything we can to forward addresses, email addresses, home addresses, phone numbers, as we get those changes now.
I did have go ahead, Brian.
I was just going to say, and to be honest, just from a national level with Molina, we're really petitioning CMS to help us perhaps be able to do some additional things, maybe through the Department of Health once some of these things may get approved.
I did have a question about the email address that we were provided for the HPRs to update information. Is there any plan or thought to maybe share that email address with some of the assister organizations? Because I'm hearing that a lot of members will call back to the people that helped them sign up initially for Medicaid for, other unrelated, questions, things about SNAP benefits. And so because they are member facing, it might not be a bad idea to engage them in updating addresses as well.
Yeah, I think that's a good idea, Sheila. I appreciate that. We'll look into that. And, I mean, we only have so many HPRs too that also have to help people, but let us look at that. And, if you've got some specific entities in mind, if you just want to email one of us, I think that would be great.
Yeah, that'd be great. Absolutely. Thanks, Emma.
Thank you.
And see, well, there's various avenues to actually be able to change our address that we have with EWS. So it would be important to share all those numerous swim lanes with customers and to just give them a choice of what is most convenient to get that end actually accomplished, to just update our address list.
Yeah, we also have been sharing that as well. I don't know what the barrier is there. I haven't, I obviously haven't worked in the system and kind of looked at what's involved with that, like through my case and stuff, but it's been a little challenge to get members to actually do it themselves.
Merce, did you want to cover any other updates from DWS?
No, I think that the only other thing, Jeff, that we have not talked about, there's a lot of mutual work and work that we end up sharing in terms of planning. There's an element of this or a burden that DWS is going to have to carry alone, which is the workload that's going to be generated once the PHE ends and doing all those reviews. So for us, the big question now is staffing. We've had a little bit of turnover, more than what we've used to seeing in the past years. So challenges have been that we are continuing to hire and have hired more people in the last 2 years than the last 5 years combined. So a little bit of a heartache there. For those of you that might know somebody that could potentially make a good eligibility worker, just a plug, in January, we're opening up another hiring for potentially up to 50 people. Just have them apply if you think they could potentially do a good job determining eligibility for the state.
Well, and two things, just on the unwinding, I think it goes without saying that this will be a regular part of a standing part of the agenda. So we'll be returning to this every month. And maybe you could spend more time on some of these other issues that have come up around how to make sure that we're staying in touch with people. Marissa, one question I had for you, specific to DWS too, is that I've heard rumors that there might be some changes coming to my case, and that y'all might be making some updates and changes there, which also seems like a great time, because as we've talked about in the past, it can be difficult to get in and to navigate, and even the texting function in terms of how people are able to get notifications, all of those things. So is that rumor true? And what part in the process are you, and how can we get involved?
Yes, an excellent question, Jesse. This is not something secretive. So I do appreciate you asking, but this was going to come your way regardless. We had another conversation with some of our other advocates, specifically Utah's Against Hunger, who kind of chair our advocacy groups. What we're planning on doing is giving a presentation on what my case efforts have been and what they'll continue to be, and give you guys an opportunity to give us some feedback. That's gonna, as you're actually aware, we do meet with advocates quarterly. I believe the December meeting might be canceled due to the holidays. However, if we get our feedback through the month of March and can actually show you the direction we're going with this, you can give us some feedback. The intent is, as you know, my case is roughly about 10 years old at this point, and there's been a lot of technology enhancements that we have not really utilized that we plan on doing. One biggest concern that we kind of started this whole project with is that my case is not as mobile friendly as we would like it to be. We were considering an app initially, but we decided to actually do something different that's going to make this a more mobile friendly app. On top of that, yes, there's some functionality that could be enhanced. And of course, we can always make this a better product. So in that effort, we've already started some development, but development is scheduled to go through the month of July of next year. Meaning that if we get your guys' feedback in the month of March, or by the month of March, we should be able to, make those adjustments. But yeah, the work has actually started on my case, and we should be able to be giving demos to folks that are interested in seeing this anytime, probably after the month of February.
And maybe a piece I could add there that I thought was a really good statistic. When my case was built, about 5% of Medicaid members had smartphones and were using that avenue to get into the system. Today, that number is closer to 70% of the interactions we have are on a smartphone or device, and that current program is not mobile compliant. So the new version will be mobile compliant and you'll be able to do more from your phone, which is an important piece.
And how many, you've said this percentage before, but how many people use the electronic system versus paper?
We roughly, out of all our members, roughly 2/3 of our customers interface with us, complete applications, reviews, or receive paperless notifications or electronic notices. So roughly about 2/3 of our population.
Okay. And in this upgrade, will there be, well, I know right now it's Google Translate, right? Are there going to be considerations for other languages, or will there be a Spanish version? Is that anything that's being considered?
Yeah, we have not gotten that far in the conversation. As we give you an opportunity to give us some feedback, absolutely, that's a topic that we can consider. But yeah, it currently uses Google Translate.
Okay.
Our last item, I guess we should probably quickly cover, is that from this group, we've developed a communication committee to talk about notices, and we've met over the past several months and had some good interactions, I think, there. We've worked on a notice together to send out to folks that are in this predicament we just talked about, where they're we haven't heard from them in a while. We know that their case is being held open. We're contacting them to say, hey, did you know your case is being held open? Here's some things you can do. For example, give us your new address. For example, work on your review should that be due. So that was a combined effort, I think, and I think we got to a very much a better product because of the advocate involvement. So we thank you for that. That's a monthly meeting that will continue. While we've tackled, I believe, only the one notice so far, it's been a good discussion nonetheless each time we've met, and I think we'll continue to work on notices to improve those. And that's all I had, Jesse. I'll turn the time back to you unless there are questions.
Great. All right. Thank you so much. Thank you, Marcy. Thank you, Jeff. That was really helpful. Thanks. Okay, Colby, I'll turn the time over to you.
Hello, thank you for a few minutes today. I'm just going to quickly share our outreach plan in response to House Bill 262, which was passed during this past legislative session and directed the department to promote children's coverage for children who may be eligible for Medicaid or CHIP. So the goal for this outreach effort is to increase awareness and increase enrollment. We have selected a state contractor, an advertising and marketing firm who will be developing and implementing the campaign. And then we're also in the final stages of a recruitment for a full-time outreach specialist who will be helping with the grassroots efforts and also managing the day-to-day activities with the campaign. For the scope of work itself, we have a couple of priorities for this project. One is better understanding the barriers and experiences of our members and applicants. So to just build upon the research that was done earlier this year, this summer, we're going to be administering a survey to recently disenrolled members and try and identify reasons why they may have disenrolled and or barriers that they encountered while they were enrolled. And the second priority is to improve the user experience on the DWS website. We really want to work with DWS with this funding and improve the online navigation for the health services, just try and make that that website a little more intuitive and accessible for individuals that are going and seeking health services and these programs. Along with those two priorities, we're going to be implementing a pretty robust social media, online, and television advertising campaign. The following tactics are in the plan, include advertising on Facebook, Instagram, WhatsApp, Messenger. So really hitting through social media and able to target our audience, our target market through those platforms. But then we'll also be looking at website display advertising. So when you go to a website, there will be ads that populate, say, the sidebar with relevant topics to your browsing history. Search advertising using Google and Bing, YouTube and video pre-roll. There will be some television programming through apps like Hulu, and then audio streaming on Pandora, iHeartRadio, and Spotify. So it'll be a pretty comprehensive advertising campaign to get the message out. And we have just not done this type of advertising since 2008, 2009. So we're excited to be more present and get some media coverage there. We'll also be enlisting a social media sharing effort where we'll create posts or emails and then distribute them to our partners to share on their platforms, whether through email or their own social media platforms like the school districts, different public programs, food banks, etc. So really working within our partnerships to get the word out through multiple channels. And through multiple trusted resources that individuals may look to for information. One thing to note is all of these efforts will be created in Spanish and English, and then we'll be driving audiences to the Covering Kids landing page, which was created a few years ago, and it solely focuses on Medicaid and CHIP, and so we'll be able to track and measure the effectiveness of each platform as individuals go to that location. And then we're also exploring some other outreach opportunities by potentially partnering with sports organizations, parent associations, and then finally, really identifying ways to specifically target the Hispanic and Latino parent population. So that's a pretty comprehensive overview of our plan, and we're excited to get going now that we have a contractor and a new staff member. So, any questions?
I see that Jesse Lydell has a question.
Oh, that's right. There you are. Jesse.
Yeah. I was just wondering what kind of time frame. I know you haven't got everybody in place yet, and you're still working on probably the contracts with the marketing firm or whatever. But is there a time frame of when you're going to start doing the social media stuff, or when you want to start doing all this social media stuff?
We have to have the funding spent by the end of the fiscal year. We also have to build the campaign, which we're just getting going because getting a state contractor took a little longer than we expected through our purchasing process. So I don't have a timeline of our start date, but I know our end date will have to be the fiscal year. So
But you won't be doing
we can absolutely keep you posted, though.
Okay, but you won't be doing anything probably before January, it sounds like.
No.
Oh, no.
No.
Okay. All right.
Any other questions?
Yeah, Colby. Well, and two things. I mentioned that we've been doing some social media outreach that we could share if that would be helpful for as you get that going. Just any of the statistics from that campaign. And is this ongoing funding? When you said it needs to be spent by I just wanted to clarify that. Okay, great. That's what I assumed, or I understood it to be.
So do you want to? Yes, it is ongoing funding, right? The reason why I'm repeating that is because maybe not everyone. There's some people on the phone who may not see.
Oh, sorry. I am nodding my head. Yes, thank you, Emma, for being my voice.
So this campaign and the outreach position.
Yes, it is ongoing.
Okay, great. That's really exciting. Right.
Yeah, I would just add there's nothing solid yet about this other part of the discussions that we've had with this marketing firm, but they apparently also have connections with chambers of commerce and with local professional sports teams, and so they have like at least put out the idea that they'd be willing to talk to some of their other clients and their connections to see if they would be willing to participate and help in getting the message out. So that's very preliminary at this point, but that tends to catch people's eyes as well, and get some listening to messages. So we're kind of excited about exploring that too.
I'm just going to put this out there and channel Randall Sir if he's on this call, but he has, and others have always, since this is an ongoing campaign, it seems like there's been discussion that comes up from time to time around like rebranding some of these programs that might otherwise not resonate with people, like Beehive Care or something to make it a little bit more accessible or approachable. And so given that this is such an opportunity with the ongoing funding, I'm just putting it out there, maybe after this initial rollout and you get some numbers and data around how people are engaging with CHIP and Medicaid. Just want to make, put that on the table, and maybe there's some potential for that down the line to think about how to make CHIP and Medicaid even more accessible to families.
Yeah, I think we have brought that up in the past, and I think that's a great idea to bring it up again, because I know other states have done that to take away some of the, perceived stigma around those programs. Wisconsin, they call it Badger Care for kids, and they call it Apple Care in Washington, and that kind of thing. And we had sort of semi-seriously batted that around a few years ago, and it just was not something that I think anyone was really ready to jump into. But I think it's good to put that out on the table, but that would have to be something that would have to be approved like up through the governor's office. But good. Like you said, as long as it's ongoing funding, it wouldn't hurt to bring that up again. So we'll have that discussion.
All right. Thanks so much, Colby. Thanks for the update. Excited to hear more. Thanks. All right, Emma, it's you.
Yeah. I'll be somewhat brief because with everything else going on and the end of the year coming up. So consolidation, I think if any of you listened to Health and Human Services yesterday, there was a very preliminary, considering it was only about 3 pages long, and the actual bill will be about 1,600 pages long. But they are moving forward on the bill to actually formalize the consolidation of the departments. And right now we are still just going through the excruciating process of literally going section by section of the code. First, we identified all the sections of the code. Now we're going through them and saying, isn't that interesting? In the human services side of the code, it says human services can do something. And on the health side of the code, it says health cannot. And so we need to reconcile that and which way are we going to go. So now it's down in the weeds. And so that is part of the process that's going on. The report that's due to the legislature and to the governor's office is due within the next 2 weeks. So that is coming together. And really, besides those two efforts, the other thing that is going on is, as I mentioned, I think last meeting, is there are continued efforts to identify the next level of leadership who will report directly to deputies or assistant deputies. So that process is going on, and I believe is planned to be wrapped up by the end of the calendar year, and some additional leadership announcements will be made. So that's pretty much what's going on in terms of the consolidation effort right now. I don't know if anybody, I know Tanya is also now sitting on the executive steering committee. Tanya, did I miss anything in terms of major effort?
No, I think you covered it all, Emma.
Okay, thank you. Jesse, and then Christine.
Yeah, in the hearing yesterday, I think it was Representative Daley Provo was asking some questions about just about the metrics and kind of how the consolidation is going to be measured. You know, where are those? Are you aware of, like, is that going to be in the bill that gets proposed, or where will those sit, that evaluation?
I don't know, honestly. I don't know that they will be specifically in the bill, but I think everyone, Tracy, Nate, you know, all the entire EDO group is very keenly aware that there are expectations in terms of performance measures and outlining those up front, particularly with the new performance measure initiative that the GOPB and the legislative fiscal analysts are now going to follow. So the fact that it's a piece of legislation, I have no doubt that there's going to be expectations of very specific performance measures. And actually the new department, we've already had some initial discussions about that. Like, let's identify, what should our key performance measures be? What do we, that's consistent with the vision and the goals of the new department. So those discussions are taking place because we know that that's the expectation. But they're not firmed up yet. So I'm sure as soon as they are, they'll be made public, and everyone will have a chance to weigh in. And Kristen, did you have a comment or a question?
Yeah, thanks, Emma. That was one of my questions. Is I missed somehow the meeting yesterday, but that was kind of some of my concerns. And it's interesting that you brought up the different in code between the two that are combining, because families saw a stark difference in the way both waivers were handled during the pandemic. So that I just want to make sure that we're going to have parents' input on what has been working over at DSPD and what has been working over at the Department of Health, and what hasn't, vice versa. I really have been so appreciative of the way that Angie has had so many opportunities for the public's input on what DSPD has been doing this whole pandemic. And I feel like she's kept our families really informed on what's going on. So I would really heavily ask that parents are involved, and then that information gets out so we can have some say in the two mergers, which I think could be a possibly great thing. But yeah, that's just my 2 cents.
No, I think that's great, and I think that is our hope too. That by merging the two departments, as an example, that we can get some more consistency, among all of the waivers or other, similar functions that we have between the two departments. But I think that's going to be an ongoing opportunity, not just at this point of consolidation. Yeah, Steph?
Yes. Would you say, how would you measure like the feedback process? Like in terms of, do you all feel like you are getting a lot of feedback throughout the process? I mean, I know that I know the opportunities that have been there, but in terms of like, are there intermediate metrics like that you're looking at beyond just like the long-term metrics for performance? But what about just like some of those process ones?
Yeah, I think that,
sense?
yeah, and this whole process is going to be iterative, right? So right now, the first level of feedback, I mean, one of the things that they have identified is the fact that we've had, about total over 100 people between the two departments involved in just pretty intensive, discussions about the consolidation. We've tried to get feedback through, some of our public webinars, through meeting with different groups. Tracy and Nate and others went out and did like tours all over the state, and actually got a lot of feedback, from stakeholders and individuals in different areas of the state. So they've tried to incorporate all of that, but I think there's more to come. So I think, once again, everyone appreciates any feedback we can get at any time. So it's not only the long-term goals. I think there are intermediate, performance measures as well that we need to be looking at. So if you have ideas, there is that on the website, the hhsplan.utah.gov. There is an opportunity to provide feedback. I would say if any group wants to have a meeting to have a discussion, we'll try, although calendars are just so difficult, but we'll try to get Tracy and or Nate to the December meeting. But I think if you want to have a meeting on a particular issue, I would say reach out and we can try to facilitate setting up a discussion to get more feedback, because I think it's going to happen. I mean, we want feedback all the time, but this transition and this consolidation is not a one and done. It's going to be, let's get as much done as we can now, and we're going to have to work out the kinks over the next couple of years. So we'd like to hear from others for sure.
Thanks, Emma. And I guess I know that I've brought this up before, so sorry if it's annoying, but in these feedback sessions and just like thinking about the Medicaid focus groups, like how is there going to be like a centralized location for like how that's being gathered, and how there can be some accountability to the public about, okay, we took in all of this feedback. Some of it was some of it was like irrelevant, right? Like I know I gave feedback and I was told it was irrelevant. Shocker that it was about something not relevant. It was about like the actual eligibility process, for example. But like, as we get these feedback, how are we going to be like figuring out, like, how do we, because I'll just get to like, I just think sometimes there's like this thing where people have like selective amnesia, where it's like, oh my gosh, we didn't know this. And it's like, yes, we did, because Medicaid members have said this before. Like we talked about, the Medicaid focus groups are all things that we all have known and been saying. So like, how are we also just kind of having some accountability about, like, some of it might not be relevant, some of it might just be not, like, it didn't impact the decisions, which is fine. But I just think people should know, because it respects their time and it respects the process, and it feels like it's a like cyclical relationship and not just like, let's come and like mine information from people and then not tell them what happens with it. You know what I mean? So I'm just trying to assess that part too, if that makes sense.
Yeah, no, I get that. And it's, you know, it's also, I think, a challenge to try to document and, well, I guess to document all of that feedback to begin with and then provide, you know, responses and updates. I know that they have been trying to, at least all the questions that have been coming up in the webinars that they've been doing, they've been documenting all of those, whether they came in the chat or they were just, you know, verbally expressed, and then documenting the responses to that. I believe they're trying to go through a similar process in terms of gathering all of the feedback that they received from the tours of the state. I think they went, I can't remember, maybe Tanya remembers, but I think they did like 28 different stops around the state. So let us take that question back to the Consolidation Executive Steering Committee and give them that feedback, because I know one of the things they wanted to do is to make sure that they documented their processes and everything that's happened, because HB 365 is asking for that accountability. You know, how did we get feedback from the public? How did we get feedback from the stakeholders? So I know they're trying to document as much of that as possible, and that's all public. So let us take that feedback back to the group and see if we can't do a better job of making sure that we're getting it and that people know where to find it.
Emma, did you, I mean, that was just to kind of, it sounds like Christine's question kind of echoed that, but I mean, I guess, is there a current place where that feedback lives?
I think the intent is to make it part of that report that is being submitted. And I honestly can't remember if they were going to post it on the website or not, but we'll find out. We can share that back out. But I know they are trying to gather all that as like appendices to the report that will be submitted, which will be a public document. So. Okay, anything else on consolidation? Okay, I'll just go through a couple of other updates. I know that we have a few items out there on rules and spas. I don't know that any of them, I guess I will ask the question if there are any questions about anything that is out there at this point. Again, we've been very conservative in terms of how much we've been doing with everything else that's been going on. I will mention that the one spa that we are pursuing at this point in time is, and it's out there on our list, to implement HB 178, which we've talked about before, which goes into effect January 1 of 2022. But this is the bill that will allow pharmacists to actually prescribe medications in certain limited areas, and so we've had to submit a state plan amendment to support that activity. We've talked before about SB 27 and 28 out of the last session as well, that allows physician assistants to basically practice and bill, certainly within their scope of their legal scope of their practice, but do it independent of physicians. That actually, we implemented all of that in our system, even though the law took effect in May. We finally got all the changes made to our system effective November 1. So providers, physician assistants can now basically submit claims back to the effective date of the law to get those paid separately. In terms of other rule changes, let's see, we basically have, I guess, solidified or putting in rule the continued eligibility requirements for that transition program. I think that's just to basically make sure that those are clearly stated in the rule. Benefits, the only change we've made really is to increase the reimbursement for adults in the UP program from 100 up to 150 each month. So this is the premium reimbursement program that's under our waiver. That amount was increased by a bill last year up to a maximum of $300 per month. So that also needed to be changed in rule. Jennifer, did you have a question?
Yeah, mine was on SB 27 and 28. The health centers have PAs who are very interested in these being enacted, and we're still waiting for DOPL to finish their part of the rules. So right now, PAs should still be treating things the way that they have been, and then once DOPL gets finished, then they can register differently. And it works out. Okay, I just wanted to double check on that. Thank you.
Yeah, because I mean, it still has to be within the scope of, whatever changes DOPL needs to make for them, that needs to be in place. But we're ready now to accept that once DOPL has finished their work. So let's see. We also, and we've talked before, how we we've done some emergency rule around our ARPA funds for the 10% FMAP increase. And again, this is just to make clear to providers that they have to attest, that they have to understand it's temporary, that they have to commit to spending these funds largely on direct care staff. So essentially putting out a rule to support that process. The nursing facility rule, this was a negotiation with the industry to make some changes to their quality improvement program. The industry was very involved in that process. So that's essentially what that rule is. And then the last rule we have out here, the extraordinary care definition. This is to support what Tanya was referring to earlier, which was Senator Harper's bill to allow for caregiver compensation when it's provided by a spouse, and trying to define what extraordinary care means for the purposes of that program. So with regards to rules and spas, that's pretty much been our activity in the last month. I wanted to mention just a couple of other state plan amendments that we are required by CMS to complete before the end of the year. So CMS just recently came out with some additional guidance related to some changes in federal law. One is with regards to our non-emergency medical transportation. And just so you know, nothing's really changing. I mean, it's still an available benefit. However, CMS has made it clear that some of the screening requirements for other providers will now apply to transportation providers and their drivers as well. So we will have to submit a state plan amendment by the end of the calendar year that basically states that every provider, so that would be the broker, and every individual driver, we're going to have to make sure that they are not excluded from the federal databases for any reason, just like we do other providers. We'll have to make sure that we have a process in place to verify that, and these are not bad things, these are good things, they're just going to be a lift, that every individual driver has a valid driver's license, that each provider has in place a process to address any violation of any state drug laws on the part of their drivers, and that each provider has in place a process to disclose to us any driving history, the driving history of their drivers, including any traffic violations, so on and so forth. So you'll see that state plan amendment submitted, and that is being required by CMS, that all states put that in our state plans. And then there were some statutory changes regarding how to treat third-party liability in the Medicaid program. So again, this is when a Medicaid recipient has other insurance available, And over the years, there have been changes to the program in terms of when the state is required to, what we refer to as cost avoid a claim. So if a Medicaid recipient has other insurance, for the most part, states are required to say to the provider, you go bill the other insurance first, and if there's anything left over, you bill Medicaid. But there were some exceptions in federal regulation and federal law that allowed the state to just go ahead and pay the claim and then collect from the third-party insurance after the fact. There are some changes that have been made. So for example, in the past, states were allowed to just go ahead and pay prenatal claims for prenatal services, and then the state would go ahead and pursue collection from the insurance. The changes are now requiring that states have to apply cost avoidance to prenatal services, including labor and delivery and postpartum. The other change that we will have to add to our state plan is that we can make payments without consideration of other insurance for preventative pediatric services. So that's not really changed. They're just modifying it a bit. And also just extending the period within which states have the flexibility to just go ahead and pay a claim when this one's very complicated, when it's for a child who's basically part of a state child support order under the state child support program. So you will see again, a state plan before the end of the year, also identifying these changes, but again, they're being mandated by CMS. So that is what's going on there. And then the last thing I'll just mention is this will take a little bit of time to work through, but UTA has informed us that they are going to be doing away with their punch passes that we have traditionally provided to Medicaid members. They're going to all electronic cards. And so we're going to be working through that issue with UTA, but you will see some changes in terms of that process that will happen after the first of the year. But they've basically just given us notice that they're going to do away with the old punch card system, and so stay tuned. We'll keep you updated on that one as well. So those are the things that are pretty much in process right now between now and the end of the year. Yes, Stephanie?
Hey, Emma. Yeah, sorry. Can you clarify maybe, or where can I learn more about that third-party insurance thing? Is that related? This is a very weird question that might not make sense, but there was an article about some of this in the New York Times in February by Sarah Cliff, and I remember that it was about Medicaid members and hospitals, this like weird billing thing, and it was related to like third-party insurance. Anyways, do you know if it's related to that?
I don't, because I don't know all the context of, or all the, what the article specifically was about. I mean, we'd be happy to, I can get these CMS bulletins to Sharon, and she could just mail them out to the committee members, to the MAC list, if you're interested in taking a look at it.
Yes.
Okay,
That would be the fastest way. Yeah.
Yeah,
Thank
we
you
could
so
do
much.
that. And then if you have follow-up questions, you can just, connect with us, and we'll try to work through it. So, okay, yeah, we'll get them to Sharon, and she can just share them with everyone.
And Emma, did you see Allison's?
Yeah, I mean, honestly, Allison, I don't know that it's a phone-related card. I think it maybe, I don't know if Jennifer Strohecker is on the call, or Jen, it's not necessarily an electronic on the phone, right? It's just more of like a tap card. Is that right?
Correct. It's a hard card. It's like the TransPass that's used by other individuals, and it just has a chip in it. So you walk onto the bus or the train and you tap the card, and it will capture the ride at that time.
Yeah.
But it is a card that has to be issued. Yeah, it's not.
Right.
Not on a phone.
Yeah, but it would be like, rather than a monthly bus pass, it'll be like, here's your card, So people are going to have to get used to taking care of that card, and you know, they'll be using that instead. But again, lots of detail to work out with VTA at this point. Okay, any other questions?
Yeah, that kind of on a related note. Are there any updates about the logistic care contract, or the I thought you had mentioned maybe a few meetings ago that was going to be going back out to bid, the transportation contract.
Yeah, Jen, do you want to give an update on that? I think that will go out on an RFP, right? Next
Yes.
year.
Yeah, sure. So the transportation contract that's currently held by Motive Care does expire at the end of March. We were able to put 120-day extension on that, so we had adequate time to put an RFP out to solicit other vendors who may want to apply for that. That is being written right now, and the technical specifications and all the contract language is being put together. Oh, not the language, but the RFP language is being put together now, and we expect it will be reviewed internally and then posted. So.
Okay, great. So if we have any questions about that or thoughts, we should send them over to you.
Sure. Yep. We're happy to take those. Thank you.
I think, Jesse, if you want to do that, but make sure that you maybe copy Tanya and myself as well. Just, in fact, what we could do is just give you the Medicaid Director's Office email, which Sharon will get that to you as well. So if you could just CC that email, because the three of us have access to that, and just address your comments to Jen.
Okay. Great.
Okay.
That sounds great. All right.
All right. Any other questions? Okay. Thank you.
Yeah. Thanks, Emma. Well, that brings us to the end of our. Oh, Laura has a.
Thanks, Jesse. Yeah, just before we close, I just wanted to check to make sure there were no additional comments or questions on the 2/11/15 waiver amendments.
It sounds like not, but we will send out a reminder, or I guess we could send out a reminder if anybody does have any comments following this meeting as well.
Great, thank you.
Yeah, perfect. Okay, well, I think that comes to the end of our meeting. We will be having our December meeting, same Google Meet time, same Google Meet place, and look forward to seeing everybody then. And hope everybody has a really happy Thanksgiving holiday if you celebrate it, and look forward to seeing you all in December. Thanks, everybody.
Thank you. Bye.